addition in will up to the 30%. In residency is a fixed routine. There is no routine morning and night. Government holiday, no government holiday. In better work-life balance in residency initially, but not in the private practice. Better satisfaction in work. Have to explain the consent procedure risk. Sometimes in private practice, you do not meet the patient and relatives directly on the operation theater, and plenty of time to read. In residency, there is already a system in flow of patients. In private practice, there is challenging in building the practice. In institute, there is qualified trained staff, but when you go the OT, the unqualified, overconfident, untrained staff generally, if you do not train ourselves, the more of the financial planning and cost analysis, the so these are the expenses monthly, but it is house staff, staff salary, housekeeping, security guard, electricity, biomedical waste, EMI, premises rent, food bill, laundry bill, phone bill, these one. But it is less than we are earning, and the periodic electrical audit, CCTV maintenance, AC maintenance, hospital insurance renewal, donations, goodwill cost, BMW consumable purchase. Initially, generally, we required the instruments, PG set, 14 lakhs, lithotripter, camera, light source, cautery, Legacy, or harmonic, lap instrument, later developed CAM, laser, RARS, bipolar cautery, Euroflow, and lastly, the robots car with the for freelancing, you need a big boot space car. And for choosing for the right location for your clinic, the demography, what your target patient population, urban or rural, accessibility, parking, public transport ability is must. Because if when you open the clinic, it is not just drain the area where you, but always also the periphery area where the most of the patient will come to you. The public transport accessibility will be there. In setting up your practice, infrastructure, interior, comfort, waiting area, consultation room, minor OT, and is- space allocation of pharmacy. Pharmacy also a big revenue generator. Hiring a staff, clinical staff, nurse, medical assistants, administrative staff, lab, pharmacy staff, staff training and compliance, digital setup, electronic medical record, telemedicine, integration, online appointment schedule, patient management, patient acquisition and retention, building a referral network with physician, hospital, RMPs, and digital presence with the website, YouTube, social media, Google, and community engagement, free checkups, awareness drives, loyalty program for the old patients, and encourage satisfied patient to the refer to the others, and hospital affiliation to collaborate. This is the free camps we organize it, and it is just a small business model which will increase with the time, and you have to develop post the success stories. And there is also the new, when you come to the practice, there is RMP cuts and ethical considerations, because this is referral system. Most of the RMP will demand a commission, otherwise you have to train them with the CME like that. In there is finance do there is more stress in the private practice. The financial pressure due to the loan, investment, clinic running cost, patient flow is uncertainty, managing staff, long hours works, and lack of work-life balance. For time management, prioritize your work and
Abhishek,
set
you need to
boundaries.
wind up.
Delegate administrative tasks, hire staff to outsource, building a strong referral network for stable
Abhishek, you will have
patient
to wind
inflow.
up now.
Time's up. Please wind up.
The For the new practice, Ayushman Bharat is a lifeline. Lot of the patient come with the Ayushman. This is our clinic. Conclusion: clinical practice require a balance of clinical excellence and business acumen. Thank you.
Thank you, Abhishek. Your talk was mainly featured on creating a small setup of you, and that's why all that cost. And probably it was giving a very negative kind of picture how difficult it is to set up. But I think the main transition that occurs from being a resident to being a consultant is your mindset change. As a resident in a hospital, you've got your consultants behind you, fellows around you, and though you might do great work, but you are not held responsible for that. Here, it is only your shoulder that the patient rides on. So your empathy, your interaction with the patient, that changes, and you have to really invest yourself in the patient's well-being. Rather than as a resident, I'm not saying all residents are like that, but there is a certain amount of aloofness. There are others to carry. I do my job. This is what I do. These many hours I work. Now the next man will come and take over. So as a consultant, it is the patient is your baby. You have to see through that child in every phase of his or her ailment. So that mindset change is the major change which occurs. All these financial things they can't occur on day one unless you have got born with a lot of money around you or married into a lot of money. But this all comes up over a period of time. So don't expect everything to be hunky dory on the day one. So you have to work towards that. So that's what I would say.
I just started, so I feel these challenges. So I discuss these.
No, yeah, those
Like
challenges.
that, I never
agree. The
expected that
challenges
someone
are
will
there.
ask the 30% cut
Yeah,
from the
but the main challenge is
patient.
here.
Yes, sir.
Hello.
Now I'm enjoying
Abhishek,
because we have three
the
doctors.
first thing is don't list your challenges. If you list your challenges, it'll frustrate you.
Yeah, it becomes.
Let things come, handle the things the way they come. And the best way to handle it is always take a decision which is in the patient's favor. Advise him that investigation which is good for him.
Yes.
Advise him the medicine good for him or her. Operation good for him or her, not in your interest. If you maintain that kind of strategy in your private practice, very soon the word will go around that this doctor takes interest in the patient care, he decides for the patient, decisions are not biased for him, then there is no end.
Yes, sir, I decided to being a only ethical practice.
So
Nothing else.
don't get carried away by what is happening around you in the market.
No, sir.
The sun is always one. So don't worry.
Correct.
Keep shining, you will be no problems. See, we are sitting here, so many practitioners in this group and in the hall. You ask anybody,
Abhishek,
ask, are you satisfied in private practice? You are very satisfied in private practice. No problems.
what sir is saying is very true. 30 years back when I started my practice, being honest, I thought whether I would be able to make my both ends meet or not. But I realized it's your honesty, your commitment, your dedication, the time spent. And now you have to manage everything to deliver a good quality care. You have to manage everything. So you mentioned 3 4 times the cuts and all. And now I'm running a 110-bedded multi-specialty hospital. As a policy, neither we receive anything nor we give anything. But we don't have any dearth of the patient. Patients are coming because the good services which you are delivering, and very soon they realize it.
Yeah.
So
Yeah. Chalo, this is a very big subject to discuss.
thank you, Dr. Patel.
Thank you, Abhishek. So we have one. It's a panel discussion. I'm not sure. So, but it's nail urodynamic testing, and Aryan Anand, SGPGI, will present. Do it right, dodge the mistake.
ये नहीं है not this one
आप हैं
ये नहीं है
तो हम बैठे हुए क्योंकि जगह नहीं थी निकलने की
एक और है इसमें अपलोड किया था इस कंप्यूटर में किया था एक और है ये रहा ना हाँ दिस वन Okay. Good morning, respected chairperson, teachers, seniors, colleagues. I'll be presenting, I have made a PPT about the very few common mistakes which we are having during recording of the urodynamic study and during the interpretation part. Actually, the urodynamic part is a very vast topic. It is difficult to cover in a short time, all the aspects. So the most common things which as a resident I encounter in the urodynamic room, I have tried to cover those. So I'll start with this, sir. First of all, I will place before you few case scenarios or few readings which have some disturbances or some abnormal type of recording on the urodynamic curves. Like the first one, we will see this and we will discuss these things at the end of the presentation. The first thing is a subtle disturbance in the P abdominal curve, subtle disturbance in the P vesicle curve. Also, again, it is corrected, and again, it is disturbed in the. Again, we see it has been corrected. We have started, and again, there has been some disturbance. So here, I would like to know what is going on actually. What should we interpret if it comes to us? Generalized type of recordings in all the curves. We corrected once. Again, it is happening.
I think
Yes, sir.
you can see P det actually going down, and
Yes,
there's
sir.
no change in P vesicle. So sometimes patient experience rectal contractions.
Yes, sir.
Okay, so that is not reflected in P vesicle.
Vesicle. Okay, sir.
Okay, so but the first one, maybe the patient is moving or there's some problem with the.
Okay, sir. Okay, sir. We will discuss afterwards. Sir.
Okay.
I have some more graphs. Now, this one shown by a red arrow, the P abdominal recording was going fine. Suddenly, there is fall in its recording, and it has reached around baseline level. This also we encounter sir,
Maybe a
sometimes.
slipped catheter.
Okay, sir.
It has come out.
Okay, sir. We'll see. Actually, this is a little bit interesting, sir. I will tell later.
Okay, sure.
Yes. This one, the P vesicle, P abdominal, both are falling, and somewhere it has gone below the zero line also, and there is also disturbance in the P detrusor, sir.
Maybe can you tell us which one is what?
Sir, red one is P abdominal, sir.
Red one is P abdominal.
Yes, sir. And the P vesicle is the blue one, the top.
The bottom one is?
The bottom one is the detrusor pressure, sir. Third one.
Third one is P det.
Yes, sir.
No, there is some because P det is actually P vesicle minus P
Yes, sir.
abdominal.
It is deduced. Yes,
So
sir.
वो लग नहीं चलो anyway.
Okay, sir. We'll see.
कुछ हाँ नीचे P det.
This one, sir, red arrow you are seeing, sir, the larger red arrow we are this part of the curve. Acha, next one, sir. This now we have seen a recording was going on good. Cough, patient coughed and it was also good. But suddenly here again the curves have fallen and now it is below the negative. It is below fallen below the zero. Both P vesicle and the P detrusor, and it has fallen below the zero. Okay, sir. This one is a little bit common. I will discuss the large arrows which we see during the recording. We feel first of all when I went, then I used to ask what is this large curve, how it came. It is usually sometimes it is always, sometimes it is present, sometimes it is not present. So, sir, we'll start with this. This is the first slide. Here, I would like to discuss about the heart of the urodynamic system. The yellow thing, which is the strain gauge, I have mentioned it separately because it is in between the recording system. This is the thing which perceives the differences in the pressures and gives us the recording. Practically, during the setting, it looks like this, and this is the strain gauge. Next is the complete setup. This is our urodynamic setup. The screen, the patient part, a little bit cut. That this is the setup. This is screen, and this is the larger screen, part of the screen for recording. Now I have made some videos, sir, recording what should we do before we start recording or what must be done. Voice नहीं आ रहा?
Calibration.
Voice था इसमें? Excuse me. हाँ सर, मैं बता दूंगा. Recorded है. Play करूँ वापस? This is the Euroflow meter. We will calibrate the Euroflow meter. Little bit, थोड़ा बढ़ा दीजिए. This is the calibration of Euroflow meter, sir. Actually, this usually most of the time it is skipped, but this must be done, this must be brought in practice, how we calibrate the Euroflow meter and what it should be. वहां से प्ले करती है ना, ओके.
आप बोलो, I think.
The Euroflow meter, we will calibrate the Euroflow meter first. I will pour around 400 ml of water into the Euroflow meter slowly, as if the patient is urinating. This must be done at least once in a week. Now, as I pour this fluid around 400 ml into the beaker, the recording goes on the screen, and the screen is recorded. We will check with the recording how much water we have poured and how much it is being recorded. This is quite simple thing. The amount of fluid which we have taken, we know that. We just pour in that slowly and we see the recording. Amount of fluid should be both equal, almost equal. Around 25 ml to 10 ml difference is okay, but should not very large. So this should give the correct recording. Now second is the setting up of pump, sir. This part I am showing the setting up of pump. Now this is the liquid normal saline at room temperature, which we are going to infuse into the patient for measuring of the bladder pressures. Now we connect this and we let the air come out through the tubes. We see a clear flow of fluid from this and no tube in the system, and then we lock this channel. After locking this channel, now we are going to set up the pump. We see the direction to the patient is like this. Along the arrow, we set the tube inside the pump, and then we lock the pump like this. Now the pump is set up for the patient side to be connected. Here what happens, sir, like we see the fluid is hanging onto my right side and the pump is here. So if we don't see and do, usually we fix it like this along it. But the arrow, if we see, it is just opposite. So we have to twist it. In this setting I am telling, we have to see and we have to set it correctly. Then only the pump will work properly and the water will go inside the bladder and proper filling recordings will be done. Now, this is one of the most important video, how we calibrate the pressure system and how we set up. Now I will demonstrate how we will set the pressure transducer to atmospheric 0, and I will also show you on the screen how it is set. Now this is the pressure transducer. This is the syringe basically used for flushing the system to get rid of the air. Now these two are the patient portals connecting to the P abdomen and P vesicle, intravesical and intrarectal or intravaginal. Now we will just allow the pressure transducer to have the air pressures from the atmosphere. That is this lining. Right now it is locked. Now I will rotate this lock in such a way that the pressure transducer now only senses the atmospheric pressure. It is locked here. It is locked here. This is locked and this is locked. Similarly, here the syringe is locked, and we will lock the patient portal also by rotating it in this position. Now the pressure transducer only has atmospheric air in its contact. Now on the screen we set the pressure transducer to 0 according to the abdominal pressure. So what I am trying to show, we have a tri-way syringe attached to it. We lock the syringe part and we lock the tube part, and we open the part which is exposed to the atmosphere. So when we do this, and after that we have to press set to 0. Now the baseline will be set. From here the recording should be there, because if we don't do this, the recordings are not set to 0. We move the tubes, we do the flushing, so it comes haphazard. So this is very important in this perspective. Now it is set to the atmospheric 0. Now I will show you how we will calibrate the pressure transducers according to the rising pressure in the system. Now I have lifted the tube for P vesicle, and we will first calibrate this pressure transducer. Now I will open the this connection towards the pressure transducer by rotating it like this.
Repeat कर रहे हो यार, वैसे भी time खत्म
Now
हो रहा है,
once
वो
we
जो
will
graph है
confirm
ना, वो
that
मैं
all
बता
the
दूं।
air in the
मैं बता
system
दे
is
रहा हूँ
out. जी
हाँ।
सर, ये एक्चुअली कैलिब्रेशन ऑफ द प्रेशरिंग सिस्टम है, ये हम वी जस्ट ओपन द वाल्व टुवर्ड्स द प्रेशर टुवर्ड्स द
That is
ट्यूब.
fine. I think
Okay, sir.
we can move. You can
Okay, sir.
explain. हाँ.
This is slide showing the effect of air. If air enters, what type of recording we will get.
What is the effect of air?
Actually, I will also explain this briefly. If air enters, the first column is just water. Whatever the pressure enters, pressure will be recorded outside. But if there is water in the system shown by the yellow one, the pressure which is entering will compress this air, and the outside the output will become very small. So this is the problem with air in the tubes which we were flushing. Now some test of quality should be there when we are interpreting a recording. First of all, I see the resting pressure. The resting pressure is never flat. It records some of the movements, breathing movements. So we see there may be slight disturbances in the recording. So next is the live signals, also called by movement of the body parts, and most important is the cuffing test. The cuff test should be equal on the P abdomen, P vesicle, and equally cancelled and represented on the P detrusor. Now the few things for importance during the course of the study, so that the recording is meticulous and reporting is just. First is very important, the interview of the patient. We provide this patient information paper to the patient to read and come what we are going to do, what we are going to record, and what will be the process, what he has to come prepared for. Second very important thing is the bladder diary. Bladder diary will give an average estimate of the bladder capacity of the patient. In cases like overactive bladder and others, we need to know how much we need to fill actually, because patient will have the recording of disturbances in the pediatric user beforehand, but he may not have achieved the bladder capacity recording. Third is the free flow, always needs to be done before recording. And the fourth is the physical examination, in which if any prolapse is present, if any neurological abnormality is present, we need to make this part of the examination before recording and for reporting. Now I will explain this also. Catheter placement. This is the double lumen catheter which we use. We place it in the important part after placing is the fixing of the catheter, which is required. I will briefly show that. After placing it, we need to fix this so that it doesn't move during the procedure. बस सर मैं लास्ट ही वीडियो इसको प्ले कर दीजिए, प्ले नहीं हो रहा. नहीं हो रहा.
Aryan, what you can do, you can show
Okay,
those initial slides.
Okay, sir.
You know,
वापस प्ले कर.
Because they are anyway not being projected well, so can't see those spacing.
Hello. Is there a way to reduce these lights here? Is somebody from the hall?
There are lights in that.
Is somebody from the hall managing?
एक सेकंड.
Can you come here?
हाँ?
Top lights.
Yeah.
अच्छा, okay. कभी-कभी एंगल में होता है.
ग्राफ दिख रहे हैं?
अच्छा, okay.
सर
लाइट कुछ कम हो जाए अच्छा.
वो एंगल पे है.
Yeah, angle होता है.
Sir, after inserting the catheters, we need to.
दृष्टि है तुम्हारे
Yes,
पास.
sir. After fixing the catheter, sir, we need to actually fix it properly to the skin so that those recordings or some subtle movements of the patient does not come. ये फिर से हैंग कर गया है.
Dodge the mistake. चलिए कोई नहीं अब जो भी.
सर एक्चुअली प्रेजेंटेशन मूव ही नहीं कर रही है, वो स्टक है. नहीं, ये तो बता दिया मैंने कि वी नीड टू फिक्स द कैथेटर. नेक्स्ट स्लाइड पे जा रहा था मैं, नेक्स्ट भी नहीं हो रहा था.
ये
अरे करो जो आपने शुरू में
summarize कर दो आप.
जी बस आ गया सर. सर वो नेक्स्ट
भैया
हो ही नहीं
please
रहा
help
था.
him.
What is I
हाँ वो.
Otherwise you summarize.
Okay, okay, sir.
अरे यार वो slide.
Now some of these. ये चेंज मत कीजिए आप, मैं करूंगा. बस आप वहां पे लाके छोड़ दीजिए. Sir, some of the graph which I showed, sir, the answers to them. Like this was the movement or tube knock. Just patient moved or someone moved the tube. So these recordings came of that only. This is the tube knock, first figure. The next one, which in which the P abdomen fell to around 0. This was the rectal catheter leaked here, so it went down.
Slipped catheter वही.
Slip catheter I will show, sir. This was just rectal catheter losing all its normal saline.
Similar है, हाँ.
This was the patient position change, because all the catheters are showing the recording. So this will be the patient position change. This one, the expelled vesical catheter, this goes below the zero level also and becomes negative. And last one which we use will
अच्छा
be
ये बताओ
last.
कि
Yes, sir.
ये can you go back?
Yes.
इसमें लेकिन ये पी डेट पी एब्डोमेन का क्या हुआ? ये एक्चुअली क्या हुआ कि ये ऊपर का नहीं समझ, हाँ?
पी
नहीं,
एब्डोमेन तो लगा है सर.
ये एक्सपेल्ड वेसिकल कैथेटर में, लेकिन पी एब्डोमेन में तो चेंज नहीं आना था.
वो उसके आगे सर, उसके आगे तो टू मूवमेंट्स हो रही हैं और वो हो रही हो तो एडजस्टमेंट का मूवमेंट्स है. ये पार्ट सर, ये पार्ट तो ट्यूब मूवमेंट्स है सर, कुछ नहीं है वो तो. यहाँ पे तो वेसिकल कैथेटर रुक गया और वी स्टॉप द रिकॉर्डिंग्स.
वो एक्चुअली रेड लाइन मिसिंग है उधर.
रेड लाइन में
एरो से पहले भी रेड लाइन मिसिंग है.
कुछ क्लैरिटी. चलो एनीवे ठीक है, ठीक है.
यू गॉट.
हाँ,
यस,
मिसिंग है रेड लाइन.
बस
Okay.
इतना ही था इसमें.
थैंक यू, थैंक यू, थैंक यू.
थैंक्स.
So we end this session and next, हाँ, yes.
All the presenters and chairperson can have a quick picture together.
Very good morning to all of you. So moving towards our next session, that is master class in female urology. First, I would like to request our new chairperson to please come on the dais. Dr. Prashant Lavania sir, Dr. P.K. Jindal sir, Dr. Balbir sir, Dr. Subhash sir, Dr. Rishi Nair sir, Dr. Yash Agarwal sir, Dr. Avjit Kumar sir. And our first lecture is on exploring link between microanatomy and the mechanics of female urethra by Dr. Divakar Dalela sir. Over to you, sir.
Very good morning, everybody. At the outset, I'd like to confess that my presentation is slightly long because I was told it's about 15 minutes and here I see 8 minutes. So my speed will be little fast. Can I have a pointer? Okay, okay, ठीक है, I'll manage it. Huh. This is a topic which is less read and less number of people have interest in this part. And it's here because of my interest. I've been reading this literature. So I'll put before you some facts related to the female urethral microanatomy and how are they related to the mechanical function of the urethra, mainly the storage. The female urethra is divided into 5 parts. This is each 20% of the entire length, and these are the currently accepted names: intramural urethra, mid-proximal urethra, mid-distal, and distal. So mid-urethra has 2 parts. And this division is because what is related to the urethra. In this part, it is bladder neck. In this part, rhabdosphincter and urethral ligaments. In this part, urogenital diaphragm. And this is below the urogenital diaphragm. This is the critical dividing line. All this is above urogenital diaphragm, and this one is below urogenital diaphragm. So let us divide this, let us understand this into 3 separate parts. I'll first focus on the mechanics of intramural urethra, and this has been told by Dr. Turner Warwick many years ago. In that part of urethra, which is first 20%, the fibers drop on the urethra from the smooth muscle fibers from the bladder, and they drop and they course around the urethra and go back. Now here I'd like you to appreciate that they are coursing around more than 3/4 of the circumference and then coming back. It is not like this. The fibers do not course just the half of it. I hope you can appreciate the difference in this and this. This is the correct version, and this is not the correct version. The fibers descend from different parts of the bladder. This is how the fibers descend from this part of bladder, course around the urethra, and go back up. And there are many such bundles shown here to you with different colors. Second bundle, third bundle, fourth bundle, 5 bundles, many bundles. Each bundle is looping around the proximal part of the urethra. If you see that in a cross section here, this is one bundle of fiber, this is second bundle. So both bundle of fibers are in the opposite direction. One in red, one in green. Then third bundle in this direction and fourth bundle in another direction. So what is actually happening is from all sides of bladder, the fibers are dropping around the bladder neck, around the proximal urethra. If you see this in magnification, why it happens like this? This is the loose fibers and this is the urethra. When these fibers pull in the opposite direction, it has a constricting effect on the bladder neck. So that is how, by virtue of the looping that through the fibers in bladder neck, urethra closes. If you see this in a filling phase, where the base plate of bladder is flat, and this is the different fibers, as bladder fills up more, these fibers get pulled laterally, and there is a closure effect here. See that? This is open and this is close. And this is more close. Bigger is the filling volume, more is the tension on these fibers. In the filling phase, there are many fibers of detrusor which are beginning from the front and going and coursing behind the trigonal plate. When